Hello to everybody.
Hello, and I'd like to introduce pulmonologist from Bolzano in Italy, Alessandro Zanforlin, who's going to talk to us again about other aspects of the COVID epidemic that we're fearing at the moment. Thank you, Alessandro.
You're welcome. I excuse if some concept will be repeated. I think that almost everything was already said. Let's look. We start from recent history. We know that the epidemic, the outbreak, started from China. Here, the first CT patterns of peripheral lesions of COVID pneumonia was described. And then the first ultrasound findings as already described. Then the outbreak came in Italy. The epidemic starts from Lodi, the Lodi area. Lodi is the home of the Accademia di Ecografia Toracica, is an Italian institution, an Italian group of chest ultrasound performers and experts. And from the first moment, our colleague from Lodi told immediately that ultrasound could be useful in the managing of COVID pneumonia. Then the epidemic spread in northern Italy, and many of respiratory physicians, internal medicine, doctors, emergency departments, and general practitioners share many images and videos in our social network page of Accademia di Ecografia Toracica. So much about ultrasound knowledge of this pathology was already and early known by the Italian community, and that made for us the things more easy. A recent census we made in Italy, in fact, showed that right in Lombardia, there was a large diffusion of chest ultrasound. In particular, many of the operators were skilled in diagnosing pneumonia. And where the chest ultrasound was not available, that was because of the unavailability of ultrasound system. So unfortunately, the epidemic started where as best it couldn't be managed by ultrasound experts. But the problem is except for protection that already was expressed by the previous relator, is what we need. We need an ultrasound machine. Not all the units have an ultrasound machine. We need to protect it. We need at least an ultrasound system with a convex probe to diagnose COVID pneumonia. But we have to provide a machine to every ward that has to manage this pathology. So in Bolzano, we did the ultrasoundization of the hospital with the aim to give to each department its own ultrasound to reduce the moving ultrasound apparat between wards, to reduce the need of ultrasound apparat protection, and so to reduce as much as possible the possibility of contagion. The in-ward ultrasound use needed wheeled ultrasound machine, more feasible in open space wards with one filter zone for the whole ward. So you didn't have to cover and uncover the machine to enter and exit every room of the patients. And the ultrasounds are maybe more feasible in single bedroom wards with the filter zone for every room and with a clean corridor. So the alternative are to buy new ultrasound machine, but to do that you have to know, you have knowledge about ultrasound machine, to know the quality of image they provide, to know the problems about its transport, its protection, the battery duration. You have to know the costs, the availability, and the delivery time. Unfortunately, in full epidemic period, if you tried to buy a new ultrasound machine, the delivery time were much longer. The alternative is the redistribution of ultrasound machines. So we have recorded unused and underused ultrasound system. We made a technology assessment to understand what was available and what was needed in the new COVID wards. And then was made a temporary redistribution where necessary. The preset we used for diagnosing COVID pneumonia was mostly a convex probe with abdominal preset with a frequency between 3 and 5 megahertz. Filters were off, compound off. The focus was put on pleural line. The depth set at 5-6 centimeters. The gain was low in order to assess the movement of the pleural line as best as possible, and the persistence also was off. So the aim was to examine as fluently as possible the moving images, in particular the sliding sign, reduce the white saturation, and enhance ring down artifacts. We know that lung is normally not visible by ultrasound, but when the disease come out, it becomes visible, in particular when the disease reaches the surface of the pleura. The typical appearance of the pneumonia is a hepatization with dynamic air bronchograms, but from the beginning of every pneumonia, there is an initial loss of air that come visible as an interstitial syndrome. The interstitial syndrome is an intermediate loss of air of the lung parenchyma. So we can assess the density of the parenchyma with ultrasound from the normal lung in which we see only the surface. We start to assess the presence of B lines that became coalescent in the white lung. The more the lung lost its air, then come the consolidation with air bronchogram, and then finally the atelectasis. So we make a real densitometry of the lung. Because of that, lung ultrasound is an unspecific exam. So when we see a sonographic interstitial syndrome, we can see a ground glass opacity, we can see a bacterial viral pneumonia, an interstitial lung disease, we can see heart failure, IRDS, surface irregularities, or a dysventilation. So let's see what's typical of COVID-19 pneumonia. We already seen what the Chinese colleagues described. Recently, many articles are comparing ultrasound appearance with the CT patterns of the lungs. Gino Soldati has proposed an international standardization of the use of ultrasound with an acquiring of images that could be elaborated by an artificial intelligence system that could give suggestions about the diagnosis of COVID pneumonia. In intensive care units, the protocol, similar to the Munich protocol, was already known since some years. This is taken from the CRT, the Association of Anesthesists of Italy. And the scoring is the same. So starting from normal lung to B lines, coalition B lines in white lung picture, and then consolidations. So in the early stage of COVID pneumonia, you can see isolated B lines starting from little irregularities of the pleural line. Then as the the situation becomes more severe, you have larger areas of white lung with consolidation, little consolidation appearing on the surface of the lung. Then finally, you have larger consolidations, in particular in posterior areas, as already described. When the consolidation go on and make themselves deeper in the parenchyma, it's a bad prognostic sign. These are other consolidation. You see that some of them are hepatization with little air bronchogram. Some of them are more anechogenic without air inside. Some consideration about the exam. In Bolzano, we aimed to make a complete covering of the whole available surface of the chest. To facilitate the posterior scan, hand was put on contralateral shoulder, elbow downwards, to move the shoulder blade laterally in order to have more scanning surface of the lung. In the lateral scan, hand behind the neck, with elbow backwards to explore axillary area. In anterior scan, arms are upward to move upwards the clavicula and to explore anterior axillary area. The exam was performed this way by continuous lung scans through intercostal spaces with longitudinal scan, as you see here. This way you can detect the alterations of the parenchyma that appear different from the normal lung pattern. You also have to learn to recognize the lung fissures. Lung fissures are the normal limits of the lobes. They can originate. They can origin some single artifact that has not to be considered as pathologic. So let's see what's useful for ultrasound in every setting. In emergency department, the role of ultrasound can be to increase the sensibility of the chest X-ray. So when, in particular, when chest X-ray is negative, you can assess with lung ultrasound if there are signs of pneumonia. So a severity assessment or a diagnosis can be made, and you can decide for hospitalization of the patient. Only when both chest X-ray and lung ultrasound are negative, and with clinical suspicion consistent for COVID pneumonia, you should perform a CT to eventually exclude the diagnosis and dismiss the patient. We used in Bolzano this schema, a little bit different from the protocol already explained. This protocol is made of 10 zones that were divided in base of the anatomic aspect of the lungs. So in the anterior, we had 3 quadrants that were representing the apical segment of the upper lobe, and the anterior segment of upper lobe, and the medial segment of medium lobe. In lateral, other 4 quadrants that were taking part of upper lobe and medium lobe, and posteriorly 3 quadrants. The upper was the posterior segment of upper lobe. The medium is the apical segment of lower lobe, and the lower quadrants of posterior and lateral were part of the basal segments of lower lobe. This mapping more with more areas can give a qualitative and quantitative evaluation and could be useful for the follow-up. So if you perform this exam every day, you can see the changes of the lung from an exam to the other. These are the scoring we have used. We have used a score based on 5 degrees of gravity, or severity, excuse me. So the first score is equal to that already proposed. The score 2 is the white lung. Score 3 is white lung with subpleural consolidation. Score 4 is consolidation larger than 2 centimeters. And score 5 were large consolidation that were visible in more than one area of the chest. So the frequently asked questions are: can lung ultrasound replace chest X-ray? Can lung ultrasound replace CT scan? Can lung ultrasound replace the real-time PCR on swab? When lung ultrasound is positive, do you hospitalize patients without having real-time PCR response? So lung ultrasound cannot perform microbiologic diagnosis. It cannot perform also cytohistologic during non-COVID times. Cannot fully replace CT scan, cannot fully replace chest X-ray, cannot replace anamnesis, visit, lab, and patient's symptoms. But lung ultrasound can integrate with clinical data, so anamnesis, symptoms, lab are absolutely mandatory. Ultrasound can also integrate with chest X-ray. Ultrasound have high sensibility, low panoramic view, impossibility of exploring deep parenchyma. Chest X-ray has panoramic view of the whole chest, but has low sensibility for early lesions and minimal dysventilation. Lung ultrasound and chest X-ray together are consistent for pneumonia, so you can consider hospitalization, waiting for swab's response to decide if the patient has to be hospitalized in COVID ward or in COVID-free ward. If both are negative, if the patient is in good clinical condition, you can consider the discharge of the patient, and it can wait also the response for real-time PCR swab at home. Together with chest X-ray, lung ultrasound can make not mandatory the use of HRCT scan. That only when the clinical question is COVID yes or COVID not. That when you have to avoid complex routes to perform CT. That was the problem we had in Bolzano, and you have to limit the number of operators at risk because exposed to the potentially contagious patient. In uncertain cases, the indication of HRCT remains, or angio CT, as indicated by the clinical conditions, as you suspect a pulmonary embolism. So ultrasound can have a predictive positive value for COVID pneumonia, in particular in condition of active outbreak in younger patient and or patients supposed with healthy lungs, in elderly patients with comorbidities during congestive heart failure, aspiration pneumonia, cicatricial outcomes of pneumonia or pleuritis. It is difficult to determine if also a COVID infection is present. On this basis, on published data of our case in cases in Bolzano, we are reading a sensitivity of 90% and specificity of 75% for ultrasound in detecting COVID pneumonia in the emergency department. So recently a paper from some Chinese colleagues had showed that the sensitivity and the specificity of ultrasound in COVID pneumonia was quite high. The number are unfortunately a little bit few, so the numbers are maybe not so strong. they tried in particular to assess the severity of the pneumonia using ultrasound that in patients already known to have the COVID pneumonia. What we can say is that ultrasound is useful to diagnose pneumonia, so to say pneumonia yes, pneumonia no, and give indication to hospitalization. The severity assessment is only partially possible because the deep parenchyma is not visible, so we have only a partial vision of the parenchymal involvement. Arterial blood gas and clinical data are more useful maybe to stratify severity and decide the correct intensity of cure for the patient. So if they need oxygen, high flow nasal oxygen, CPAP treatment, or needing for ICU. In the ICU, the COVID pneumonia management consists in monitoring consolidation and disventilation. So my work in the hospital during the epidemic was to perform a daily mapping of the patient in the ICU. You have to consider lung ultrasound for the reevaluation when the patient is worsening to understand what's happening. So increase in white lung areas, you can consider the change in treatment from high flow to CPAP in the normal wards. When the increase in consolidation determines to consider recruitment and pronation for patient with intermediate care and intensive care units. The monitoring of the benefit of pronation and CPAP can be monitored by ultrasound. You can monitor the recruiting in intubated patient, that making a daily mapping. So you have a sort of comparing from day to another of the general situation of the patient. You have also support to monitor complication in other procedures, so pneumothorax after the positioning of the central vein or a pressure trauma, and you can manage other clinical problems like cardiovascular problems, abdominal problems. So in the ICU, we use this protocol similar to that of the Munich colleagues with a daily mapping and scoring. We can see that we could manage the consolidation, so the sideway proning by performing a recruitment test and monitor the evolution in proning position. So you could see that a consolidation became a white lung, so the increase of the air in the lung was visible. That's an example. On the left, we can see the consolidated lung is anechogenic. On the right, after recruitment, there was the appearing of some air bronchogram. So this patient was finally prone to try to improve his lung situation. The medium-term evolution in ICU, I don't know what you are seeing in your units. Is there there are two evolutions. Older and thinner patients tend to have a diffuse pattern with diffuse pleural irregularities and with wide lung, with patchy distribution that remains quite stable during their stay, and also a diminution time from ICU. Instead, younger obese tends to have posterior consolidation with a preserved anterolateral surface. In conclusion, we have seen how the outbreak spread and how knowledge exploded from northern Italy about use ultrasound in COVID pneumonia. We see what we need for performing this exam and how to perform it. lung, we know, is difficult to be studied in the deep of its parenchyma, but the loss of air let it explorable by ultrasound. So with our scoring, we can assess the severity of the disease, make a good triage and diagnose pneumonia, and then manage all the problems we can meet in the intensive care units and other wards. Thank you very much for your attention.
Andrew, for a nice, neat, concise presentation. I have a number of questions for you, and I'll put this to you. One of the questions is, and I think you may have answered this, how many times a day do you do this ultrasound on the patients, and do you do every patient every day? And how many patients does this involve on your intensive care unit, and whether you do it also outside the intensive care unit?
My work was organized this way. In the morning, I was in the intensive care unit, where a maximum of 16 patients was hospitalized. So in the moment of the peak of epidemic, we had 16 patients. Every day, initially every day, we try to map the patient. When the patients were quite stable, we try to do it each other day. So one day yes, one day no. But the critical patients were monitored daily. If the situation required it, the other colleagues also in the afternoon performed another exam to see if there were other problems. In the afternoon, I was involved in the triage in the tent of the emergency department to perform the screening of the emergency department of the new COVID patients. So I performed daily about 10 exams in the morning, and what was needed in the afternoon.
Okay. And another question is, do you change your gown between patients when you're doing your rounds, or do you keep the same protection on for every patient?
In the intensive care, both the environments were considered as contaminant. So my gown was put in at the beginning of the session and put off at the end of the session. In the intensive care unit, we used the additional single-use gown only for patients with other multi-resistant bacteria, for example, where an additional protection was needed not to spread other pathogens between patients. But the gown, the general dress for protection, was considered as a second skin. So I held it for the whole session, both in ICU and in emergency department.
But I'll ask another question of Alessandro here. Can you detect fibrotic changes with lung ultrasound? I think this may also be a question for Conrad. Alessandro, can you detect?
Well, yeah, I think.
Yeah.
Can I speak?
Oh,
yes.
Here we go.
Okay. I think that there should be a monitoring in the next month of the most severe patients to look for the evolution of the fibrotic residual of this disease. Maybe the time for performing a control CT is as these scarce, these fibrotic residuals become stable, or they disappear. So I think they will need at least 2 or 3 months, not before.
Conrad, there's another question here you may be able to answer. Using contrast enhanced ultrasound, have you used it on any of these patients? Unmute yourself.
Yeah, to be honest, yes. And the thing is, friends of mine in the hospital nearby, they did it already. This is why I was showing pictures of the peripheral lung embolism. The thing is, in fact, you can see with contrast-enhanced ultrasound. Well, if there's a pneumonia, you can. The big thing about the lung with contrast-enhanced ultrasound is that you already have two phases. That you again have two phases of the lung perfusion. In fact, you can see the embolisms as like infarctions in the periphery. You can remark it, and what you can also see, if you've got a pneumonia, you can see the hyperperfused areas, and this is what you really can see as hyperperfusion. I was trying to do that with Doppler ultrasound, even with good probes, and the thing is, it's hard because the pocket ultrasound Doppler devices are very limited. And the patient is, of course, breathing, and it's really hard. You can see maybe the breathing rate of the patient with the Doppler, but you don't get a proper signal. It's very hard to get. Sometimes you get it, but it's very it's hard to standardize. If you put a contrast media in it, you can. Is there a bubble? Is there a bubble thing, or is there no bubbles inside the consolidation? So you can really see, is it an infarction? Maybe what I think, what was the in many cases the case, but we have to have some more data from pathology into that as well, and I think we have them in 2-3 months.
Okay, I'm going to just wrap it up with one final question here, and it's for either of you. COVID-19 causes microvascular thrombosis. Can the ultrasound detect poorly aerated surfaces of the lung? Alessandro.
Can you repeat the question, please?
Microvascular thrombosis. Yeah. Can ultrasound detect poorly aerated surface of the lungs? I think I can answer this, and I think you probably can. Yes, very small areas. We have seen it on our imaging on the ITU, but you got very 3 to 5 millimeter areas of low reflectivity, and this may be microvascular thrombosis. Who knows? Until we have the pathology. Yeah,
I think they're out of the detection capability of the ultrasound. You cannot diagnose microthrombosis from the surface. I think it's quite impossible. You can see consolidations, but you cannot make a histologic exam with ultrasound.
Yeah.
I think, Alessandro, if we have the lung ultrasound machines, we were even possible in that also from the kidney septum or from the liver septum. I think due to the air artifact, we really see whether there's a vascularization or not in the micromillimeter in the range. But the thing is, you're completely right. We have to have a histologic correlation between that. I think there might be a chance, and there was preliminary data. There was the editor 2 days ago or something like that of the group. I was not sure if it's from Italy or from Germany who already was thinking about it. And they said, "Damn, yes, I'm quicker." I think we might see, but we have to study that. If you have contrast ultrasound, we really think and also for correlation in the ICU. But let's wait and see.
Yeah. Okay, there are many questions here, and I can't take all of the questions because we already run over time by 12 minutes. I thank both our presenters today for excellent talks. I remind the audience that these will be available online on the EFSM website. And I thank the audience who have managed to join us here today, and I hope you've found this an interesting presentation, and I hope it helps you in your daily practice. Thank you, everyone. Thank you, Conrad. Thank you, Alessandro. Bye-bye.
Bye.